So thank you very much for having me, and for Bernie Costa for inviting me to give a lecture today. And happy to do this. I've done these types of talks before, but I will miss everybody laughing at my corny jokes. So I'll have to assume that everybody's laughing. So today I wanted to pick a sexy title. So something that was interesting to the group and drew people in. So I wanted to talk about male rejuvenation and the real secrets to male rejuvenation and where we are now and maybe where we're going in the next coming years. And get to the right screen here. In a way of disclosures, I have none relevant to today's topic. Tessa has stolen my thunder a little bit in the background information.
I'm sorry for doing that.
No worries. I'm not too proud of the Penn State football team right now, but the Steelers are certainly doing well. So I'm proud to be a Steelers fan. Originally from Pennsylvania, trained at Geisinger, and then did an andrology fellowship in Toronto. And what I'm really proud of is joining Hartford Healthcare and being able to help develop a men's health program here to really look at multidisciplinary care for men. And I've also enjoyed working with the University of Connecticut urology residents in the hospital as well. So what are we going to talk about today? And I like history, and as evidenced by, I think Bernie went offline, but his background of urinals, he's very into history as well. So I'll touch on it. He can probably give us a better lesson in the history here. But I want to get into talking about restorative therapies for erectile dysfunction, and you can see several of the modalities we'll be talking about today. Looking at hypogonadism, and also known as andropause. Looking at some other endocrine pathways that some individuals are looking at, specifically the growth hormone pathway. And then what are some outside the box rejuvenation techniques? Really, cosmetics is a big one that some people are engaging in, and there's some evidence for as well. And we'll try and wrap it up with some conclusions at the end. And this image here to the right, this is an old wood carving from the 1500s out of Germany. And this is the Fountain of Youth. The Fountain of Youth has been depicted in many different imagery and stories, and we'll get into that a little bit. So without further ado, I want to talk a little bit more about the history of male rejuvenation. So the Fountain of Youth is this mythical body of water. It restores the youth and vigor to anyone who drinks or bathes in its water. And it's been depicted in many different stories, many different images. You can hear about it in stories as far back as 5th century BC in ancient Greece. And it really was featured amongst a lot of stories in the Caribbean population during the age of exploration. So during the times when Europeans were coming over to the Caribbeans and to the New Americas, there were stories of the Fountain of Youth. And the explorer we've probably all heard about is Ponce de Leon, who was reportedly searching for the Fountain of Youth when he traveled to Florida in 1513. So for anybody that still wants to look, it's been found. There's now a park in St. Augustine, but I will throw out the disclaimer, there's been no known cases of age reversal yet, so don't rush down there right now. In fact, I think Florida is still a hot state, so I would not advocate for it at this time. So let's put this all in relevance. I find it really interesting that we're talking about a fountain of youth for individuals in the 1500s. So this is a life expectancy curve from the 1770s, so not even the 1500s, but the 1770s up until about 2018. And you can see even as far back as 1770s, individuals were living on average between the high 20s to maybe early 30s. But these are still individuals who are looking for, quote unquote, the fountain of youth, ways to kind of reestablish the vigor of their youth. So where are we now? Well, this is the most recent statistics I could find. This is from the National Center for Health Statistics. This is data up until 2018, and it was just published in 2020. And so the average life expectancy for men right now is 76, for women 81, and overall 78. And so this is leaps and bounds beyond where the life expectancy was in the 1500s or 1700s and where we are now. So a couple points I want to bring up with this slide. One is the fact that we're certainly, individuals are living longer. And so there's going to be more changes with age and comorbidities that may drive more people to be looking for that youthful rejuvenation as well. Also, the discrepancy between men and women. So this is something I'm always advocating for is men's health, and recognizing that there are gender differences. Female health and women's health movements have been around for the past 2 decades or more, but really looking at men's health specifically has not been a focus until as of late. And I want to challenge the audience to look at this graph and not accept it at its face value. Why do we accept that men live shorter lifespans than women? And so that's just, why do we accept that? Is that acceptable? Should we be living the same amount of time? What is the gap, and why is there a gap there? So just something to think about. So as we know, and as I mentioned, with aging and comorbidities comes some altered physical and mental capacities. These are things that maybe we're looking back to our youthful years and wanting to get back to some of those physical and mental capacities. So as a result, individuals have sought out anti-aging treatments. And this has resulted in the use and really a lot of misuse of certain hormonal supplements. Also, there's been certain restorative treatments that have been touted, and we'll get into those a little bit later in our talk today as well. Also, we've seen the advent of gender-specific practices. So again, women's health has been around for a few decades and is represented with certain federal groups, but men's health is not well represented with the NIH. And this is something that I think we need to look at addressing. And I put in quotes here, evolving, because you can look back the late 1800s, early 1900s to a lot of the quote unquote snake oils that were touted to help with certain maladies and comorbidities that went along with aging. And hopefully we're moving more towards scientific evidence now, where we can really determine if our treatments are helping and reversing some of these aging changes. But as I'm going to get into, a lot of these techniques and modalities are still relying on that anecdotal evidence and aren't really getting over to the scientific evidence we should be relying on. And then lastly, I'm going to close with the Latin for first do no harm. So in the Hippocratic Oath, we really have to remember that we have that dedication to helping individuals, but first doing no harm. And so that's going to be the question with a lot of these new treatments is there potential that we're causing harm? Okay, so back to our outline, moving on, I want to look at erectile dysfunction in some of those treatments. And I'll warn you now, I do have too many slides today, so I'll try and move along. So how do erections work? So many of you probably are well aware of this. For normal erectile function to occur, I described to men, you really need three things. You need nerves to work, so you need sensory input, parasympathetic nervous innervation. You need vascular flow to work, arterial inflow and venous compression, and the psychology, the mental state of mind needs to be in the right place as well. So what happens in erectile dysfunction? What's the pathophysiologic mechanisms? And there really can be a lot. You can have an impact on any of those three factors. So again, nerves, blood vessels, psychology. So age is certainly one of the biggest factors. Hypertension, diabetes, smoking, we all know those can affect vasculogenic factors. Medications can impact erections and testosterone levels, and certain psychological factors as well. So the data in the graph on the right, this is from the Massachusetts Male Aging Study. The first thing I talk to men about with erectile dysfunction is level setting. What is normal? This isn't something that men talk about in the locker room very much, but erectile dysfunction does happen very commonly as you age. So if you look at the 50-year-old bar, it's about 48% of men are struggling with erections to some degree by age 50. That's almost half of men. So I like to level set with men and set expectations that it's okay that you're struggling with erections. It is very common. Now let's talk about how we make it better. So high prevalence, and this is what I try and get across to the men I'm seeing as well. So what are our treatment options? So this is according to the American Urologic Association, who updated their guidelines in 2018. It used to be more of a stepwise approach in treatment options, and they really took those treatment options, which they had in a vertical algorithm, and flipped it to a horizontal algorithm. So if you look at what's depicted here, you use shared decision-making with patients to talk about what's important to them, their values, priorities for them and their partner, and then you present all of these options. So as I describe it to men, here's the toolbox. Here's all the tools. Here's what's FDA approved and available right now. We have phosphodiesterase inhibitors, vacuum devices, intraurethral prostaglandin suppositories, intracavernosal injections, and penile prosthetics. This is what we really have right now. And one thing that I'm commonly hearing from men, whether it be their own questions or things they've seen online or in the newspaper, because there are a lot of ads in the newspaper about this, is, what else is there? Is there restorative options available? And specifically when I take men through intracavernosal injections, I commonly hear, well, how often do I have to do this? Is this going to restore my erections? And I have to remember to remind them, this is like the phosphodiesterase inhibitors in that ICI is going to give you an erection each time you use it. It's not going to improve your overall erectile quality. So let's take a pause here. This is what we have available, but let's shift to what are some options. How do we rejuvenate the penis, so to speak? What are our restorative options there? So the aim with any of these restorative options is going to be to try and reestablish that penile function and reverse some of the dysfunction. And so we're going to use different medicines, technology, techniques that we're going to talk about here. So what has been studied is penile low intensity shockwave therapy, platelet-rich plasma, stem cell therapy, and lifestyle optimization. That's what we're going to talk about today. We're not going to talk so much about supplements. And I did get one request from somebody who shall not be named about talking about penile enlargement surgery. And I thought that would be a good topic after the fact, but I kind of ran out of time and maybe a future topic. So let's dig in on low intensity shockwave therapy. This is probably the most studied of these techniques. So the hypothesis here, according to the picture you see down in the bottom of the slide, is that the energy with these low intensity shock waves is going to activate the cells in the penis, specifically some of the stem cells, and cause the release of growth factors. This will result in some angiogenesis and hopefully better erectile function. Now, the image you see at the bottom is obviously a cartoon. And if you look at it, your disbelief is well grounded in that nobody is going to see a response like this, where you have no blood vessels on the left or complete occlusion to these great blood vessels on the right. So this cartoon is, I would say, an aggressive, dramatic view of what might happen with low intensity shockwave therapy. And I think I kind of cut it off here, but the text at the bottom says, for illustrative purposes only, results may vary. So this is pulled from one of the low intensity shockwave therapy clinics. And the problem here, as we're going to get to, and you're probably hearing and reading between the lines, is that a lot of this isn't evidence-based. So what is the evidence? So first off, does it work in animal models? And so Tom Liu in San Francisco has studied this in a lot of rat models, and there's been some work out of China as well. And we've been able to demonstrate that, yes, we do activate some stem cells in a rat model. So imagine a tiny little shockwave device that they put on the rat penis, and that's what they've done in these studies, and demonstrated that they can activate the stem cells and some of the downstream growth factors there. So now the question is, does it work in humans? So what we really need here is you need a large, randomized, blinded, sham-controlled study, which is possible with these devices. A lot of the machines do have the ability to run in a sham mode where the machine makes a noise but doesn't actually deliver the shockwave energy. So does it work? And one of the real questions is, not only does it work, but does it have long-term efficacy? So this is one of the longer studies. This is an Israeli study. It's also one of the larger studies, which has been a problem with many of these studies, is small patient recruitment. So this is 156 men using an electrohydraulic style machine to trigger low intensity shock waves, and they followed their men out to 2 years. And they used an erectile function score, a standardized questionnaire, the IIEF, to look at their results. So as you can see from the data here, about 2/3 of men were successful at 1 month as improving the scores by, I think it was 4 or 5 points. It was what they defined as clinically meaningful. Whereas when you followed it out to 2 years, about half of those lost their effectiveness. So it was only about 34% had a clinically meaningful improvement in their erectile quality at 2 years. So really lost effectiveness over time. You also have to think about, how is this given? So it's normally given in cycles where men get treatments every day or every couple days for the first week or two. And some studies have begun to augment with kind of these booster courses of shockwaves as well. So there's a myriad of different regimens that are being used to study whether this is effective or not. And a lot of the studies have shown that the individuals that see the most benefit are those with the non-severe ED. So the ones who probably would be responders to the phosphodiesterase inhibitors already. So that also brings up the question, which is better here? Is it the occasional as needed sildenafil, tadalafil, or should we be putting men through these treatments and the costs associated and the waning results over time with shockwave therapy? So the other question is starting to look at what regimen is most appropriate. And as you can imagine, there's essentially an infinite number of different regimens that can be used. So this is another study. I picked this one. This is one of the few US-based studies. This is by Ranjith Ramasamy. He's down at the University of Miami, a very good academic urologist there. He has a machine and was able to treat 87 men. And in this study, they were looking at two different protocols, daily for 5 days or 3 days per week over 2 weeks. And the men in each arm received the same number of total shocks. So theoretically, the same amount of energy delivered for the end effect. The mean increase in the erectile function score was 2.7, and the erectile hardness score increased by 0.6 and 0.5. So essentially, they showed equivalency. But my real question here is an erectile hardness score, and here's an example, and I'm sorry if this doesn't project well, but looking at this erectile hardness score improving by 0.5 point, is that clinically meaningful for most men? And I'm not sure. I'm not sure if the answer there is that it's clinically meaningful to be offering this treatment. My other comment would be that a lot of these trials, as I mentioned, have not been in the US. Many are in Europe and Asia, and not to discount their studies, but we really do need better studies. And many of these are mixed. So I've demonstrated 2 studies that showed some benefit. And if you look at the most recent review, this was in the Journal of Sexual Medicine in 2019, looking at the 11 randomized studies on low intensity shockwave therapy, there was a small positive effect on erectile function, not in all studies, but in some. And when you group the data together, that effect did exist. But my concern here is that a lot of these studies are also sponsored by the device companies. And I know of at least one, if not more, studies that did not get published that had negative results. Not harmful results, but didn't show a clinically significant benefit with shockwave therapy. So my concern here is, does this really represent what is seen in the studies if we have negative studies that aren't being published? So I'm just concerned about some bias there. The other complicating factors here are that there's different devices, different regimens, and different study designs. So as I mentioned, these devices, they're essentially like shockwave lithotripters used for kidney stones, but used with a handheld device and a lower energy. There's electrohydraulic and electromagnetic, just as there's different devices for kidney stones as well. And so it's hard to compare the different devices and really claim that you're looking at apples and apples. There's different regimens, really. You can create whatever regimen you want. And there's been several that have been studied, but even the best regimen hasn't been determined. There's different study designs. A lot of these have been cohorts, but really what we should be doing is the best level of evidence, which would be a blinded, sham-controlled, randomized study. And so that's what we need more of right now. And the risks. I put a question mark here because we really don't know what any long-term risks are. Probably not much. There's some local irritation and discomfort during the treatment in some men, but we don't know what any long-term risks might be well yet. So as a result, these devices are not FDA approved for erectile dysfunction at this point. The European Urology Association guidelines, last published in 2017, was kind of on the fence. And their quote was, definitive recommendations cannot be given at this time. And the problem here is that many local clinics are offering this. And if you look at for example, the local Hartford paper on any day, as my wife likes to remind me, there's a half-page ad every day for one of these local clinics. The other concern I have is we're not comparing apples to apples. The true shockwave therapy uses shockwave energy. And many of the machines used at some of these alternative clinics are not true shockwave machines. They're actually using acoustic sound wave technology. And so they're using the data in some of these randomized studies that says shockwave machines work, but they're using a device that really isn't the same type of device used in those studies. So I do tell patients to be very careful, and this is something that we are not doing at Hartford Healthcare currently. So moving on, platelet-rich plasma. So now we're going to talk about injectables. So platelet-rich plasma is even a little bit different than I realized. It is a blood specimen that's centrifuged, and it's to isolate the platelet-rich plasma. So it's not the full suspension above the red blood cells. Here in the image on the right, it's actually that orange segment. It's the most dense portion of the plasma that's centrifuged. So it goes through 2 centrifugations, and then you collect that platelet-rich plasma level in the test tube, and that's what you're using. Because you're not actually manipulating or treating the sample, it's exempt from FDA regulations. And so that leads to some of the pseudoscience we're going to talk about here. So why does this work? Why are people studying this? Well, in that layer, there's a high amount of platelets and growth factors. And the theory is that that's going to help upregulate cell regeneration with an injection into a target organ. So again, the next question logically is, does it work? Do we have proof in animal models? And again, in rodents, we can do a cavernous nerve injury model and have been able to demonstrate with platelet-rich plasma injection, there's better erectile recovery versus a control. So sounds promising from an animal model standpoint, but then again, can we cross that over to human studies? And the problem here is that despite, if you search online and you count the number of clinics offering this for erectile dysfunction, there is only one study in the literature on this. And this was a safety study. This was out of Wake Forest. So Ryan Terlecki is down there with one of his fellows on this paper. This was in a small investigational urology journal in 2018. And this was looking at the partially the regenerative properties, but really the safety of being able to use a platelet-rich injection using a fibrin matrix that they had developed as well in only 17 patients. And really, this was not just ED. This is a spectrum of different urologic conditions. Only 4 patients actually had ED, and there was a small improvement in erectile function, but it wasn't really designed to study that. They reported that the injections appeared safe overall with some bruising only, but again, serious word of caution, one study only. We really need better science here. So the theoretical risks, again, this is not only from ED data, but from the use of platelet-rich plasma in many other modalities. It has better acceptance in certain orthopedic literature. Treatment failure is certainly a concern, and contamination. So vampire facials are this technique where you get microdermal abrasion, and I believe this is Kim Kardashian, you get microdermal abrasion on the face, and then you overlay platelet-rich plasma, so it's basically getting into the skin cells. And there was a clinic in Arizona that actually had 2 cases of HIV transmission because they were not following sterile protocols in their centrifugation machine. So, the concern here is it's not a small complication, and you really need to make sure you are at a reputable clinic that's offering these treatments. So it has been demonstrated to be effective in other disease states, but the bottom line here is human studies in ED are quite limited, and we really need more data. So moving on, stem cells. Again, another very attractive option. This is often the treatment is often started with liposuction to remove adipose tissue, and then the tissue is processed to really concentrate the adipose-derived stem cells as well as some endothelial precursor cells. And that's what's going to be used for reinjection. And the theory here is that these can differentiate into a variety of cells. They can help to regenerate angiogenesis and release growth hormones to support the reversal of any damage in the penile tissues. Because you are manipulating the tissue to get the stem cells, this does not fall under FDA exemption, and we're going to get back to that. So again, does it work? So Remy here is using his Viagra. He wants to know if there's something better. So the stem cell injections likewise have been shown in rodent models to improve erectile function, not only in cavernous nerve injury this time, but also in diabetic erectile dysfunction and prostate radiation as well. So Remy's moving on. He's done with Viagra. He's moving on to stem cells here. But can we extrapolate this to humans yet? Again, very limited data. I'm going to talk about 2 studies. So the first one on the left here is looking at, this was a study out of Z Urology. It is a private practice group. Michael Zachalski, for any Survivor fans, was on Survivor. So he was the penis doctor on Survivor. And he has a private urology group in Florida, in Coral Springs, I'm sorry. And he demonstrated, he wanted to do a study looking at stem cell therapy for ED. They had 8 patients. They did not define the etiology of their ED. And they did report an increased peak systolic velocity with stem cell treatment, but really this is just anecdotal results. You can't really extrapolate a lot from 8 patients. And they were also looking at the safety, and they reported no significant adverse effects. So this is the second study that's in the literature. This is a very specific population. This is post-radical prostatectomy. And they did not use adipose-derived. They used bone marrow-derived stem cells. And they divided the population into 4 groups, and they used escalating levels of bone marrow-derived stem cells. And my biggest problem with this group is, yes, they showed improved erectile function from 0 to 6 months, but there was no control. We expect improved erectile function with time in men after radical prostatectomy. But again, I would look at this more as just a safety trial, very small group, and no serious side effects amongst these 8 patients. So what are the risks here? So again, administration site injections, treatment failure, contamination, but also think about the picture on the right here. Stem cells can differentiate into anything. We're injecting them to try and get growth factors and differentiate into some of the healthy tissues in the penis, some of the spongy tissues, some of the vascular tissue, but there can be tumor development as well. And so there has been case reports of tumors developing at the site of stem cell injection. So another thing to be aware of. So as a result of a lot of the abuse of stem cell therapy by many stem cell clinics, the FDA did announce in 2017 much tighter regulation and oversight they're going to be taking in this field. And so that's ongoing now as well. But I think the bottom line that we need to take away with regards to stem cells and erectile dysfunction is more high quality research is needed. So what are the take homes here? What do our societies say? So again, the AUA 2018 statement is that some of these restorative treatment options really should be considered investigational. And likewise, our North American group for sexual medicine considers them experimental, and they should only be conducted under research protocols. And as you'll notice, based on not only national online websites, but even local groups, this is not being done. There are many clinics that are offering these treatments, and I always tell men really to be careful, and I give a word of caution. So bottom line, lots of buzz, not bugs, lack of data right now, and it's not ready for clinical use yet. Okay, lifestyle optimization. So just one slide on this. As you may have noticed, I like to include pictures on my slides to keep you interested. So what do you think you find when you Google lifestyle? Yes, it is condoms. Okay, so I got my picture up there for this slide. So what does the AUA state? So lifestyle modifications are included at the top of the algorithm for treatment for erectile dysfunction, according to the AUA. And this is looking at improvements in diet, physical activity, and overall health. So what does the data say? This is actually a very good review for anybody who's interested by Maiorino in the American Journal of Andrology. And this put together a lot of the data on individual studies. And there has been good studies in weight loss, diet adjustment, physical activity, smoking cessation, and that has demonstrated improvements in erectile function with adjustments in these lifestyle factors. Alcohol has kind of mixed results. There certainly can be detrimental effects with heavy alcohol use, but there's still the question, is there a good amount of alcohol intake that can actually improve erectile and vascular health? And then lastly, I'll throw this out here, preventative care. This is the mission of our men's health clinic, is preventative care, multidisciplinary care. And I can't speak enough to really staying ahead of some of these factors to keep men healthy. Smoking is one of the biggest ones. I told a patient this morning, I was seeing him for ED, but he's still smoking. I'm trying to make him better, but he's trying to make his erections worse. So preventative care is key. All right, moving on, keeping on our timeline, andropause or hypogonadism. So again, I want to go back to history. Let's talk about how do we find out about testosterone? What have people before us done? Again, people have been looking for this fountain of youth for years, for centuries, really. And so even as far back as the Romans and the ancient Chinese, they were using testicular extracts. They didn't know what testosterone was, but there was something in these testicular extracts that they knew was working. And we started to figure this out in the 1800s. And so Berthold figured out that there was changes in roosters when you castrated them. They realized that yes, this is confirming there's this masculine substance in the testicles. So many of us have heard of Brown-Séquard for the spinal cord injury and the condition associated with that, but he's also famous for researching testosterone, really. He was using guinea pig and dog testicular extracts, and he was actually injecting himself. And he found he had improved strength and mental abilities, and it created this elixir of life fervor. And for any that don't know and haven't seen a guinea pig in a while, this is one in the bottom right. And then shortly thereafter in the 1900s, there were two individuals. This was a German and I believe an Austrian chemist who discovered the chemical structure of testosterone and were able to synthesize it, and both received the Nobel Prize for this. So taking you back to the textbooks, medical textbooks, and the physiology in testosterone, I like this picture because the pituitary gland looks like a scrotum, so it seems very relevant to the urology population. So testosterone is made by the testicles here down at the bottom. That's stimulated by the gonadotropin release from the pituitaries. And then the testis is making the testosterone. Some of that testosterone spills over into estrogen, and there's negative feedback on the sperm production side and the testosterone and estradiol side back at the brain level that keeps things in balance. And the testosterone that's floating around in the bloodstream is not all free. Actually, only 1 or 2% of it is free. 30% of it is bound to SHBG, and 68% of it is quote unquote bound to albumin, although that's a loose association. So I like to look at the bioavailable and teach men about what's the testosterone that's having its effect in your body. That's the bioavailable testosterone, and that's the albumin bound and the free testosterone. So what's testosterone involved in? You know, it's not the most specific symptoms, but it's involved in sexual development, sexual and reproductive function, bone mineral density, certainly metabolic pathways, and overall well-being as well. So I wanted to include a low testosterone picture here. And one of my residents was very kind to give me a picture of himself working out in the gym. So I appreciate that. This failure to produce testosterone can come from many different sources. It can be primary, meaning you have a testicular failure, secondary failure to make testosterone. That's a brain-related deficiency in the hypothalamus or pituitary. There's what's called late onset or age-related hypogonadism. And lastly, medication-induced. And so one of the biggest contributors that I see in young men with hypogonadism is either previous abuse of steroids and anabolics or chronic narcotics. Methadone is a big one. I've seen men with severely depressed testosterone levels on chronic methadone. And then getting back to the aging process, we know that testosterone goes down. So the question is, when does it start going down? How much should it be going down? So beginning in mid-30s to 40 years of age, depending on what study you look at, testosterone begins to decrease in men. And on average, this is about 0.5% to 1 or 2% per year. So how do we evaluate it? So blood work to look at testosterone should be done in the early morning. This is important. This is not as essential in older men, so after 50s, 60s. And that's because some studies have found that circadian rhythm in testosterone is blunted in older men. We don't just check one set, we always check 2 sets of blood work, and that's recommended by the AUA and the Endocrine Society, who both released guidelines on hypogonadism in 2018. And it's very important to assess symptoms as well. So on the table on the right is from the Endocrine Society guidelines. And as you're going to see, a lot of these symptoms are not very specific. In fact, the specific symptoms are only 3 items. Then there's suggestive symptoms and signs, and a lot of non-specific symptoms and signs. So I'm very careful to tell men that men with symptoms, it's not always due to testosterone. And even when we replace testosterone, it may not always fix symptoms as well. And the important point at the bottom here is that you need to meet the criteria for both low testosterone, meaning a total testosterone below 300, as well as symptoms to offer treatment. We're not treating the number alone. We're not treating symptoms alone. You need to have both to be a candidate for treatment. So I haven't used Brown-Séquard's testicle extract in a while. I don't think it's available anymore. So let's move on to treatment options that we still have. So these are the treatment options that are currently available. We have different types of testosterone gel formulations. There's patches, different injections, cypionate, enanthate, undecanoate. There are buccal tablets that are still available and used rarely, testosterone pellets, AKA Testopel, and there is an oral formulation that was just approved in the US, I believe last year. Still variable insurance coverage, so not using it very much. And then the other thing to think about is all of these are going to decrease the HPG access. So do we have anything outside the box, any restorative treatment options? And this gets into the clomiphene, the HCG, and the aromatase inhibitors, which I'm not going to be talking in a lot of detail today. Here, I just have a little bit more detail on some of these treatment options. The patches and the gels are nice for easy daily surges in testosterone. Transference is a concern for those types of medications. Injections tend to be the mainstay for a lot of my men. They're dependable, less expensive. And the pellets they supply the longest effect, but does require a procedure every 3 to 6 months. So what are some of the general side effects of testosterone? Polycythemia or increased hematocrit is certainly one of them that we have to watch and worry about at times. Obstructive sleep apnea exacerbation is something that needs to be screened for. There's a theoretical risk of lower urinary tract symptoms, prostate disease, cancer. We expect the PSA to go up a little bit, so that's okay if that increases. You don't want to see it increase markedly though. Testicular atrophy, because you're shutting down the HPG access by giving testosterone from an outside source, so the testicles will shrink. Infertility, again, shutting down the HPG access is going to decrease the FSH, Sertoli cell stimulation part of the pathway, and sperm counts will go down. Essentially, testosterone has also been studied as a contraceptive. So you do not want to use it in any man who's planning a future family planning, certainly in the near future. And cardiovascular morbidity. So this was a hot topic in kind of the early 2000 teens. It was reported in 2 studies, a Vegan and Finkel study. There was an increased evidence of vascular events in both of these studies. The concern is there were issues with the statistical analysis in both these studies, and there's been numerous cohorts after this that have demonstrated cardiovascular safety. So we really don't have the answer on this, although there is a black box warning on most testosterone substances at this point that mentions the risk of cardiovascular morbidity. So I updated this graph. My talks a couple of years ago had a graph that showed testosterone usage doing this, just taking off. But this is a more recent graph I found that looks at testosterone usage and spending. This is based on Medicare spending. So testosterone marketing campaigns started in the early, just before 2010, and that's where we saw an increase in testosterone spending and usage. And we really, around those 2013-14 studies is when we saw risk warnings starting to come out. And that's where you see the change in the direction of the curve where testosterone usage began to come down as well. But the point of showing this is to also show you that even though testosterone usage has come down, it still is leaps and bounds above where it was even 10, 15 years ago. So where were we 10 years ago? This is the pendulum here on the left side of the screen. You saw these low testosterone ads everywhere. You saw these ripped older men who were on testosterone and had this rejuvenation appearance. And then the pendulum swung because we heard about the cardiovascular risk. We heard about harm. We saw the lawyers take part and start to say, have you been harmed by testosterone? And there was a good article in Time really looking at, is menopause real? Is this something that we should be treating? So this begs the question now, are we over or under treating? So let's look at the risks and balances here. Sorry about all the pop-ups here. So potential benefits. So we can improve sexual desire and function. This was demonstrated in the testosterone trials. This was a well-performed randomized trial that demonstrated improvements in libido and somewhat in erectile function, bone mineral density, mood, body composition. Those have all been demonstrated. And then there was also a good VA study in 2011 published by Shores that actually demonstrated in hypogonadal men who received treatment had a lower mortality rate than those who did not receive treatment. And so there has been some studies showing we may impact mortality as well. The question is still that cardiovascular event studies, really 2 studies that demonstrated increased risk. The problem is the testosterone trials and the randomized trials have not been powered well enough to detect a small difference. You would need thousands of patients in these studies to really detect the small difference that was suggested by the previous 2 trials. So again, are we over or under treating? From an evolutionary standpoint, if you're an evolutionarist, you can think that we're designed to reproduce. So once you reach your 50s, 60s, 70s, our bodies don't know what to do with testosterone. We know testosterone declines with age. This is data from the Baltimore Longitudinal Study of Aging. So what percent of men have a hypogonadal testosterone level? It's 20% and 60 and above, 70 and above is 30%, and up to half of men who are 80 and above. And then this is data from a Boston study looking at symptomatic men with hypogonadal symptoms and low testosterone and how many are being treated. And they described it as an iceberg effect, where only 12% of men are being treated. I'm not advocating that we need to treat the other 87.8%, but it is something that we need to be aware of. And then we get to a little bit of the medical ethical question: is treating late onset hypogonadism appropriate? If you look at FDA labeling of these medications, it's specifically for primary or secondary testicular failure. Is late onset hypogonadism really meet one of those definitions? And you can argue that both ways, I would say. And I've heard both sides of the argument. And I think here we got to strike the balance. Testosterone is not a panacea. It is not the elixir of life. We need to realize that. The graphs on the right-hand side here show an overlap of the red and blue. These are showing the distribution of men with various testosterone levels and the likelihood that they would have these symptoms, and whether they're symptomatic or asymptomatic. And the key here is just looking at the overlap. There are symptoms of decreased morning erections, erectile dysfunction, decreased frequency of sexual thoughts. There is a huge overlap between these, whether you're looking at total testosterone or free testosterone. Put another way, if you look at these Venn diagrams here, you can see, again, a lot of overlap. And the key here is we want to find those men who meet the definition of low testosterone. So if you look at the circles on the right, that's the low total testosterone circle. You want to identify those who will benefit. That's the men with symptoms. So that's the big circle on the top. So the overlap between the two of them, that's our target. We need to rule out any cardiovascular risk factors, and you want to find an appropriate treatment option. Okay, so I'm going to move on now and talk about other endocrine options. And the one that's been studied the most is the growth hormone pathway. And again, you'll see a lot advertised about this online. So the key here is that testosterone replacement therapy may not improve all the symptoms of hypogonadism in men, specifically related to body composition. That's the target of the growth hormone medications. These medications have been shown to increase lean body mass, decrease adiposity, improve overall lipid balance. But there certainly is a history of growth hormone substance abuse. And so off-label use of this medication was made illegal in 1988. Now, with that being said, people are creative and have found other ways to supplement growth hormone without using growth hormone specifically. And so that's with secretagogues. Secretagogues are substances that are going to result in a greater release of growth hormone. And you can see the listed names of several of these substances, which I'm not the most familiar with, to be honest. These mimic growth hormone releasing hormone, or they act through the ghrelin pathway, and they're increasing growth hormone. Side effects are not well known, and fluid retention is seen in some studies. There really is a large lack of longitudinal studies and really not a lot in the literature about this. And as a disclaimer, I do not prescribe any of these agents and have a healthy bias and concern about them, but it is something that I do hear about. Now, with that being said, my book will be coming out next month. So if you would like a signed copy, please let me know. All right, and then moving quickly into cosmetic rejuvenation. So again, something that I don't focus on, but when you think about male rejuvenation, these are things that are starting to become more popular. Botox is one of those substances. It was approved in 2002. In 2018, the most recent data I could find, there was over 7 million procedures, Botox procedures in the United States. About 500,000 of these were in men. Typically, this is done for facial wrinkles, neck spasms, amblyopia, hyperhidrosis, which is excessive sweating. It's also used in the urologic world for detrusor overactivity. Side effects tend to be fairly mild when used in these other reasons, like bruising, swelling, flu-like symptoms, rare risk of very serious side effects. And the bottom line here is that you really want to see an expert. Oh, and I did find very interesting, apparently Botox for men is also known as Brotox, which I thought very interesting. So male pattern hair loss is also something that we hear about. It's also known as androgenic alopecia. And it's something that men are looking back to their youth, wanting to get that youthful head of hair back. And these are some of the mainstay of treatment options. Finasteride is certainly one of them. Again, we see in the urology world. In the hair loss world, it's a different dose. It's a 1 milligram daily Propecia dose. And that it works through prevention of conversion of testosterone to dihydrotestosterone, which has effects at the scalp level. Topical minoxidil, which is a vasodilatory agent, can also be used, aka Rogaine. Hair transplants are certainly an option. And then the question again is, now can we use some of these other restorative treatment options more than, instead of focusing on the penis again, can we use things like stem cells or platelet-rich plasma on the scalp? And the greatest data here is in platelet-rich plasma. And again, looking at the studies, there's very mixed results. This was the best review I could find. This was published earlier this year. And this was a review of 13 randomized controlled studies. 13 sounds like a lot, but then you look at the total and it's just 350 patients. So again, relatively small studies. And there were 7 studies that favored increased hair density with platelet-rich plasma injections, and 1 study that suggested increased hair thickness. But again, a word of caution here. There's a huge confidence interval when you look at this group data, a lot of heterogeneous data, and unclear risk of bias in some of these individual studies. All right, so wrapping it up, let's see what conclusions we can draw from this, what we've talked about today with male rejuvenation and any secrets that we've revealed. So one of the take homes is some of the historical facts that I wanted to drive home. We certainly are living longer now than ever before, but there's still a gender difference. Women still live longer than men. Why? And I think a lot of the why is differences in how men take care of themselves compared to women. Preventative care is one of those big factors. There's multifactorial changes that go along with aging. Specific men's health specific age-related changes include erectile dysfunction. The restorative therapies have a lot of buzz. Data is limited. Proceed with caution. That's my take home there. Standard treatment options still include first, lifestyle optimization, the phosphodiesterase inhibitors, injections, and implants. Male hypogonadism, remember testosterone is not the elixir of life. Patient screening and selection is still essential here. And then some of the cosmetics. There are treatments that work. It's important you see an expert though. So the bottom line here, the real secret is there are no shortcuts. That's my takeaway. Proactive care with a multidisciplinary team seems to be the key, and you want to see an expert when dealing with some of these issues. So thank you very much for your attention. I'll turn it back over to Tessa and the team to help with the Q&A, and I'm happy to take any questions. Please feel free to type them in the Q&A section.
Dr. Bieniek, I should have had my microphone on during that time, so you could have heard my laughter during certain parts. So I'm sure other people must have enjoyed your presentation as much as I did.
Thank you.
And I know at this point, if you have questions, we can open up Dr. Costo if he wishes to ask anything. And if you're interested in talking, you may raise your hand using the Zoom function, or you can type out your question in the chat box.
Tessa, I'm not on video, but I guess I'm unmuted. Can you hear me?
I can hear you, and I will free up your video for you.
Okay, all right.
So go ahead and.
All right. Jared, the first graph that you had showing a decrease in sexual function, etc., beginning in the 40s and 50s and increasing as one gets older. Does one seek treatment at Tallwood when the symptoms interfere with their lifestyle, or if they don't interfere with the lifestyle, does one just accept it and do other things? I don't know if that makes any sense.
It does, yeah. And I think, so the age range of patients I see for erectile dysfunction is teenagers to 90s. It's the full gamut. And you can imagine those 3 factors, vasculogenic, neurogenic, and psychogenic, have different involvement in those different age groups. And so I think, and the takeaway is the treatment options tend to be the same, but the first question is how it's impacting a man's sexual quality of life. And from there, we talk about treatment options. And it's a joint decision-making model where we talk about the risks and benefits. And as I described, I open the toolbox and see what are the right tools. Some men say none of the tools are right, and they're comfortable with their sexual lifestyle and engaging in alternative forms of intercourse, not necessarily classic forms of penetrative intercourse. And sometimes seeing a sex therapist or trying one of the other treatment options is appropriate. So for each man, it's different.
Thank you.
And I had a question typed in from Dr. Banover, he wrote, "Hey bro, great talk. But after RP ejaculation gone, erections are shocked, orgasm should live on. Is there a relationship between erection and orgasm events?" If I read his typing properly.
Yeah, so normal physiology is following ejaculation, there is sympathetic innervation to the penis, which causes the detumescence or the erection to go away. So that's normal. There can be problems with reaching orgasm, whether it be premature or delayed. That needs to be parsed out as well. Oftentimes with erectile dysfunction, there can be some premature ejaculation because you need heightened stimulation to get the erection. And the problem is then you're that much closer to reaching ejaculation. So I see that fairly commonly as well. And there certainly are age-related changes with orgasm as well, with regards to delayed orgasm, weaker orgasm, less ejaculate fluid. One of the biggest culprits is other medications as well. Certainly the SSRIs are a big culprit in causing ejaculatory changes. Hey, Bernie.
Any difference in the people who come in, whether they are married or unmarried, widowed, divorced, etc.? What's the role? We've talked mainly about males. How much involvement in treatment do you find that you're getting female involvement with the patient?
No, it's a fair question.
Do they come in?
So it's a fair question. And there certainly are all different sexual practices I see in the office. So I'm very, very quick, and I've learned from my own mistakes to assume nothing. So with every man that comes to see me to talk about sexual function, I always ask single, married, dating, male or female partners, or both, so that I know what their background is and we can gauge that conversation to whatever type of sexual activity they're trying to be involved in and whatever barriers they see to getting there. In cases where there's issues with a partner, if it's a female partner, then I try and help. I do recommend following up with the female partner's gynecologist typically first. Often it's perimenopausal or postmenopausal changes with vaginal tightness, discomfort, lubrication. Those are changes that are very common. So working with a gynecologist with different lubrication or topical estrogen supplementation is helpful. But I think there's a gap here where we have there's women's health centers. Men's health centers are just starting to come to fruition like we've created. There's a lot of practitioners that specialize in male erectile function and sexual function. There's still a gap in female sexual function. And I think there's a lot more that we don't know about female sexual function and dysfunction, whether it be desire dysfunction or discomfort with intercourse. There are more people that are trying to specialize in these areas. There's a little bit of a paucity in the Hartford region. So it's been a little bit of a struggle to try and help some of the partners of my male patients.
I have two more questions here. Does a men's health program include collaboration between specialists like urologists, cardiologists, endocrinologists?
Who asked that question? That sounds like a setup.
Well, I'm going to say it's Dr. Welsh.
Okay, all right.
So it might not be a setup.
So yeah, so I think the ideal men's health program, and if you're seeing my screen, I apologize for all the pop-ups. I don't know what's going on. The ideal men's health setup is a multidisciplinary collaboration. And so the ideal collaboration is going to be between primary care specialists who have an interest in men's health and specialists who take care of conditions that are associated that men often struggle with, or they may be unique to men or more common in men. And there needs to be a give and take between the specialties and the primary care physicians. There also needs to be the recognition from the specialists that the conditions they're treating are not unique. You need to not live in the silo. So as I describe it with erectile dysfunction, one of the most common things I see, I can't just focus on the erections. I got to focus on the guy who's smoking, the guy with cardiac risk factors, the men with uncontrolled diabetes. I'm doing them a disservice if I'm not touching on those other topics and making sure that we're preserving not only their future erectile function, but cardiac function and their other health factors. So yes, collaboration is important. And the most common specialties that would collaborate would be urology, obviously. I mentioned primary care, cardiology, endocrinology, weight loss is actually very important. Sleep medicine is also important. Geriatrics can get in there as well. The weight loss, both surgical and medical, and then mental health. Mental health is big. Men don't talk about this stuff. So our men's health center in Hartford, our East Region program, our developing program in the Fairfield region has specialists in all of these areas. So we have collaborators in all these areas that we have touch points with. And then the key to our men's health program is the navigation. So I can put a referral. We know at the ground level, all of us are involved in medicine. When you put in a referral to see a cardiologist, for example, that referral goes into a stack of faxed papers. It goes into an electronic work queue. These things don't necessarily get followed through with. So we have a nurse navigator whose full-time position is just to help men navigate that. So we set up the referrals. He or she follows up with the patient, follows up with the other office, make sure the patient is seen. So the problem is we have very good intentions, but the connecting of the dots often doesn't happen. So with that nurse navigator, we're able to help navigate the system for men. And so that's what our program is built around, not just having the specialists, but making sure we connect the dots.
I have a question from Vic to ask you to please elaborate on local PDE-5 treatment options and efficacy.
Okay. So the phosphodiesterase inhibitors.
Thank you for saying that because
there's a number available. So commercially available in the US right now I'll use generics, would be sildenafil, tadalafil, vardenafil, and avanafil. Tadalafil and sildenafil are generic at this point, so they tend to be the two most commonly used. And efficacy is highly variable. It really depends on the patient population that I'm seeing. And the other concern is that I see a lot of men with advanced erectile dysfunction where medications worked most common thing I hear is the medications worked for a while, they lost effectiveness, and now I'm seeing you. And that's where we get to more of the second line treatment options. They all work through the same chemical pathway. They're all trying to increase the nitric oxide in the penis with sexual stimulation and prevent the breakdown of nitric oxide. So they're trying to promote more blood flow and more sustainment of the erection. So harder erection, longer lasting erection. But there's only so much that they can do. And I will usually try different medications in men who are seeing an almost therapeutic response. But the man who tells me he's getting a 20% erection with a pill, I'm not optimistic that another pill is going to provide an adequate response unless we have some dose escalation we can work through. For example, up to 100 milligrams of sildenafil, 20 milligrams of tadalafil, and of vardenafil.
And I think we are now hitting a couple minutes over time. So if you have another minute or two, there's a couple more questions. But it is now 1:02.
Yeah, so anybody needs to jump off, please feel free to email me. You can direct message me on Twitter or whatever, but go ahead, Tessa.
Where do vacuum tumescence or compression devices, sheaths, etc., fall in the current offerings for ED and effectiveness, professional support and training?
So great question. So the vacuum devices are in the algorithm. They're in that horizontal algorithm from the AUA that I talked about. And so I discuss them on an even playing field with a lot of the other treatment options. The I recommend medical grade devices, so not the local sex shop type devices, which can be cheaper, but can also have more risk because they don't have vacuum limiters. You can actually hurt the penis with a device if it's strong enough. The medical grade devices, it depends on what study you look at. I usually quote about 80% of men are able to get it to work okay, but most men don't like it. There are problems with the device, with the ring. The ring has to be quite tight to be effective. You can only leave the ring on for a maximum of 20 minutes. And there are so many devices on the market. I try and limit my involvement in that professional support that you mentioned in the question. I usually refer patients back to the device manufacturer because the devices are all a little bit different. And I want to make sure they're getting the best recommendations possible.
And I think at this time, we're going to have to call it an end because we are in overtime, but there's been a lot of questions. So you can email Dr. Bieniek directly. And we thank you for joining the Hartford Medical Society today for this lunchtime learning. Be sure to join us for our next session, December 2nd, all about yellow fever in the United States. Thank you again. And thank you, Jared, for an informative and entertaining presentation.
Thank you,
So,
Jerry.
Thanks. Thank you for having me.
everyone, have a great day.
Thank you.